special initiative from Enerzal Zero and in memory of late Dr. K.K. Garwal sir. Today, Dr. Kalra sir will take us on to one of the important topics, that is iron and diabetes. Dear viewers, as you know that type 2 diabetes is a common and ever increasing worldwide health problem. Iron overload is a risk factor for diabetes. The link between iron and diabetes was first recognized in pathologic conditions, hereditary hemochromatosis, and thalassemia. But high levels of dietary iron also impart diabetes risk. So, with this, let me hand over the platform to Dr. Kalra sir so he can take us through on today's topic. So, over to you.
Thank you, Mr. Rahul, and good evening to everybody who is logged in with us today. I really enjoy being with you, all of us being together in this journey of diabetes essentials, in this journey of learning more and more about diabetes. And the beauty about knowledge, the beauty about education, about information is that the more you learn, the more you feel that you are ignorant. The Upanishad also says something like that. In the Upanishad, it's mentioned more education or more learning puts you into darkness, even deeper darkness, as it were. What the author of the Upanishad is trying to say is that the more we learn, the more we feel the need to learn more. And this is very true about a very simple subject, the subject of iron and diabetes. So today, please allow me to begin speaking about iron. We'll talk about iron and metabolic syndrome, specifically about iron and diabetes. Now, iron it's an element, it's a metal. We've all read our chemistry, and almost all of us, including me, have forgotten it as well. But it does enjoy a place of pride in the atomic table, in the periodic table. It has the atomic number 26. It can come in as ferric or ferrous complexes. It can be present as in isolation as well. And by mass, it is the most common element on Earth, even more common than oxygen. Our adult body, however, contains just about 4 grams of iron, just 4 grams. And out of this 4 grams, about 3 grams is hemoglobin, 0.005% of our body weight, just 3 grams of hemoglobin. And yet, look at the words, look at the characters that we ascribe to iron. Look at the adjectives. Iron Man, as strong as iron. How much strength does this 3 grams have to give us the life that we enjoy? And how is it that our body is able to regulate this 3 grams of iron in such a precise manner? The answer is that most of the iron is present as hemoglobin, and it can also be present as other heme proteins like myoglobin, for example, in the muscles, and cytochrome P450 in our mitochondria. But this hemoglobin that is present, it goes through multiple cycles. So every day our hemoglobin is being formed, and it is also being broken down and recycled. So this recycling is so constant, so well managed, that we rarely get zero iron in the body. There are also other proteins and other enzymes that are dependent upon iron for their structure and their function. And all these are essential for life. So therefore, this 3 grams of iron, this 3 grams of metal is actually essential for life. And because it is part of our mitochondria, it impacts each and every part of our energetics. But iron is a double-edged sword. There is a lot of data to show that iron is linked with insulin action, or rather inaction. Iron regulates metabolism in many tissues. This metabolism, because of course it is present in the mitochondria, this impacts fuel homeostasis. It also influences the adipocytes. Adipocytes are able to sense iron. So in all these multiple ways, iron acts upon insulin sensitivity, or it can create insulin resistance. At the same time, iron can influence beta cell function as well. It can induce oxidative stress. It can impair mitochondrial function in the beta cell. And so therefore, it can reduce insulin sensitivity. It can also reduce insulin secretion. Many other organs of the body, for example, the muscle, the adipose tissue, the liver, All these are also influenced by iron. So therefore, by multiple mechanisms, it is possible that iron actually increases the risk of diabetes, both through insulin secretion and insulin sensitivity. For insulin sensitivity in various organ systems of the body, including the liver, the adipose tissue, and the muscle. Is there data to support what we are saying? The answer is yes. Actually, iron overload can increase the risk of diabetes, especially in situations such as hemochromatosis, especially in diseases like thalassemia. But do note that these uh, sentences that we are saying just now are related to specific types of diabetes: bronze diabetes, hepatogenous diabetes, perhaps thalassemia. But even for the routine type 2 diabetes that we encounter in our clinics, increase in dietary iron may be associated with an increased risk of diabetes. Corollary: iron deficiency may lower the risk of diabetes. Recurrent phlebotomy or donation of blood may protect against diabetes. Our colleagues in nephrology are very well aware of the sweet spot or the Goldilocks zone in which they have to keep iron and ferritin and hemoglobin. If the iron is too little, too less, then also renal disease progresses very fast, and uh, there are it leads to suboptimal health. But on the other hand, if you increase the iron too much, increase the ferritin too much, and if hemoglobin goes above a particular level, roughly above 11, then also renal disease worsens very rapidly. But this data is not supported by epidemiological data from our country. We have such a high risk of diabetes in our country. We also have so much of iron deficiency in our country. The iron deficiency has not protected us from diabetes. We focus on pregnancy these days, and it is said that pre-pregnancy dietary heme iron intake is associated with an increased risk of diabetes. Heme iron intake is also associated with increased risk of gestational diabetes. And also non-heme iron. The less the non-heme iron, the more the GDM risk. Does this mean that we should not prescribe iron to women in pregnancy? I doubt if that would be true. The data that we have does not come from our country, from India, where as it is, the baseline iron levels, the baseline hemoglobin levels are very low. So even if we accept the situation of Goldilocks, the Goldilocks syndrome, and we feel that we should keep iron in the perfect Goldilocks range, neither too much nor too little, still certainly as a country we are on the lower side of optimum. There is more data also which shows that if plasma and urinary iron levels go up, then obesity also increases and other complications and acute coronary syndromes increase. So it's not just about diabetes, it's also about other aspects of metabolic syndrome. Now we've learned so much and so many bad things about iron. Now suddenly I am feeling afraid. Is iron actually such a bad thing? Is iron actually associated with metabolic syndrome? To answer this question, we actually thought and we created this concept known as Rubro metabolic syndrome. Rubro metabolic syndrome. Rubro means red in Latin. And this concept of Rubro metabolic syndrome was co-authored by experts from every continent, from India, from South Africa, from the United Kingdom, Mexico, and Australia. So 5 authors from 5 continents. Why we justify the word Rubro metabolic syndrome is because iron and metabolic syndrome do seem to go hand in hand. The word Rubro implies redness, and that is what heme gives to us. It also implies low-grade inflammation, which is what metabolic syndrome is all about. If Rubro and metabolic go hand in hand, inflammation go hand in hand, and the redness go hand in hand, then perhaps we can understand that lack of Rubro can also cause disease. And anemia actually can worsen outcomes of metabolic syndrome. Why is that? Because anemia will cause tissue hypoxia. Tissue hypoxia will exacerbate the micro and the macrovascular dysfunction. And all the target organs of the body will get impacted by this. So whether you're talking of microvascular uh, organs such as the nerves, the kidney, and the retina, or you're talking of macrovascular organs like the cardiovascular system. All these are impacted negatively by tissue hypoxia. Tissue hypoxia also reduces the healing of diabetic foot ulcers. And one method which has been used successfully to improve diabetic foot outcomes is oxygen therapy. Now, Rubro metabolic syndrome is very vast. Let us see how it impacts us in our OPD as primary care physicians, as diabetes care providers. Sometimes our treatments can lead to anemia. Metformin can be associated with malabsorption of vitamin B12. And if you have a patient with anemia, with megaloblastic anemia, the cause might be metformin. We have to supplement with B12. Pioglitazone can also induce anemia. This is because of fluid retention. It is a dilutional effect. It is also thought that ACE inhibitors and ARBs can be associated with anemia development. So we must be aware of these factors: metformin, pioglitazone, ACE inhibitor, ARB therapy. On the other hand, SGLT2 inhibitors and DPP4 inhibitors have a beneficial impact on the kidney function, on the viscerometabolic function of the kidney, on the interstitium of the kidney, and therefore they have been shown to be beneficial for patients with anemia. So the treatments that we use in metabolic syndrome can cause anemia. Anemia can be associated with complications like we've already mentioned, both micro and macrovascular. So whether it is kidney or uh, nerve or retina dysfunction, whether it is cardiovascular or diabetic foot ulcer dysfunction, you will find that anemia is coexistent with that. It is an independent risk factor for that, and it reduces the outcomes. It worsens the outcomes. Therefore, what do we say? All persons with metabolic syndrome or its component conditions, the whole, diabetes, hypertension, obesity, dyslipidemia, fatty liver, all persons with metabolic syndrome or its component conditions or its complications, diabetes and any target organ damage of diabetes, must be screened for anemia. So please look at the tongue, look at the conjunctiva, do a hemoglobin, please. A hemoglobin alone may not be enough. It would be a good idea to do a complete blood count with a peripheral blood film. The peripheral blood film will give you a lot of idea about the etiology of anemia. Microcytic hypochromic, think of iron deficiency. Macrocytic, think of vitamin B12 or folic acid deficiency. Other counts also, they will also help you decide what is the etiology of anemia. The reticulocyte count will help you. And it would be a good idea if we can do an iron study. Iron studies are very pragmatic, and we'll talk about that later. Because before you manage anemia, you must know the etiology. We should give mebendazole, we should give iron, but we should have a reason also for treating anemia because it's going to be a long-term affair. So we should do a pragmatic clinical, biochemical, and hematological workup. Number one, to understand the severity of anemia. Number two, to understand its etiology, its cause. And number three, to see what effects it is having on the entire body. Does it have an effect on psychology or cognitive function? Is it impairing cardiovascular or respiratory function? Neurological function? So we have to do that. And let's come back to iron studies. When you do iron studies, what you advise is usually a serum ferritin, a transferrin saturation, and a total iron binding capacity. It is very important to get these tests done, especially in kidney disease and in heart failure, because the transferrin saturation will tell you how aggressively to treat iron deficiency. Do remember also that all anemia is not iron deficiency, and all iron deficiency will not present as anemia. Iron deficiency may be so-called subclinical, which means you will get very low levels of iron, low levels of ferritin, a low transferrin saturation, a very high uh, TIBC, total iron binding capacity. The hemoglobin may be 11, 11 and a half, 12, 12 and a half, and you may feel that this is not clinically significant. But when you take a detailed history, you will find that actually the patient is enjoying suboptimal health. I've realized in myself as well and in many of my patients, sometimes my history taking is wrong. So if I ask, according to the NYHA classification, if I ask, do you feel breathless upon routine activity? And the patient replies, no, I don't feel breathless at all. That's not complete history taking. I have to ask, madam, what is your routine activity? If the routine activity is just sitting on the sofa and lying down on the bed the entire day, not even going up to the front yard, not even going for a 100-meter walk, and then the patient says, I'm not breathless, that is not a sign of good health. So we actually I have to ask in quantitative way, how comfortable do you feel when you go for a walk? Madam, are you able to climb stairs without getting breathless? Are you able to walk without getting breathless? How long do you think you would have to walk in order to get breathless? Half a kilometer, 1 kilometer, 10 kilometers? When you walk, when you climb stairs, what is the limiting factor for you? Is it that your breath begins to give way? Do you become breathless? So that means we will think of cardiorespiratory or hematological issues like anemia. Or is it that your legs give way? Your legs get tired. Maybe then we begin thinking about calcium, vitamin D. If your legs give way, what happens, madam? Is it the knees? Is it the proximal muscles of the leg, or maybe the distal muscles? What part do you think of your body is the weakest? If it is the distal muscles which are the limiting factor, it is just possible that the patient has Burgess disease. So take a good history, screen and diagnose, and remember once again that all anemia is not iron deficiency. All iron deficiency is not anemia. Subclinical iron deficiency is an entity. And if you take a good history, subclinical might actually turn out to be clinical. It is just that the hemoglobin is not low, not all that low, but the uh, clinical features were not obvious to us initially. WHO defines iron deficiency, severe anemia rather, as a hemoglobin less than 7. How I remember is this because our target HbA1c is also 7. So severe anemia, according to the WHO, means Hb less than 7. But we should not wait for the Hb to come down to 7 before doing our iron studies, before doing a proper workup. And certainly, we should not wait that long before we begin managing. Now, how do you manage anemia? Uh, you should manage with the hemopoietic preparations. Various iron preparations are available, both oral as well as intravenous. The oral iron preparations that we usually prefer are ferrous fumarate and ferrous ascorbate. So use any trade name that you are comfortable with, and your friendly team from FDC will be talking to you about different preparations of iron that they have. The earlier, older intravenous and IM, intramuscular iron preparations, were associated with a high risk of allergic reactions. But the newer generation IV ions are quite safe and effective. And the drug of choice is intravenous ferric carboxymaltose. So this is the drug of choice that we have. IV iron should be used in patients with severe anemia, where you want swift response, where oral iron is not tolerated or is not effective. Even if you suspect that oral iron will not be effective or it will take a long time, it will take 1 or 2 years for the iron stores to come up. Let us say transferrin saturation is below 13%. Then it would be a good idea to give IV iron. Iron therapy, whether oral or intravenous, should be monitored at regular intervals. You can monitor with hemoglobin, and you can also monitor clinically with a sense of well-being. And if required, you can do iron studies at regular intervals, maybe at annual intervals. When we prescribe iron to our patients, we do medication counseling as well. So for oral iron, I'll tell my patients the stool color will change, it will become black. Please don't worry at all. It means the iron is getting absorbed. The time that you go to the toilet, early morning, late night, in the afternoon, that may change for a few days, but don't worry, you'll get used to the new system. If you're taking iron at night, please don't take calcium along with it. Please don't take an antacid along with it. Take it at a different time. If you have to take both iron and thyroxine, take them at different times of the day. Thyroxine early morning, iron you can choose to take after lunch or after dinner. If you're taking iron and semaglutide, that is an antidiabetic drug, again at different times, semaglutide will be empty stomach, iron can be in the afternoon or at dinner time. Along with iron, whether oral or intravenous, we have to institute non-pharmacological measures and also other pharmacological measures. So diet, exercise, optimize vitamin D, optimize other micronutrients and other macronutrients as well. Treat other factors for anemia like vitamin B12 or folic acid deficiency. And usually the products that we have now, the oral iron supplements, they do contain these hemopoietic supplements in adequate quantity. In most patients in India, it would be prudent practice to give an anti-helminthic as well, a single dose of mebendazole, and repeat after 6 months. If you plan to give erythropoiesis stimulating agents in chronic kidney disease, like erythropoietin or its analogs, then these will have no value until iron deficiency is corrected. So first you have to get a serum iron study done, correct the iron deficiency, preferably with intravenous iron, and then move ahead. Intravenous iron will also help in heart failure. And I would like to thank Dr. Arnav from AIMS Rishikesh for having explained the concept to me. What iron does is, iron goes into the mitochondria. It works on the mitochondrial enzymes. And when it goes there in adequate quantity, the mitochondrial enzymes become more efficient. That is why the bioenergetics of our cells improves. And the cells include the myocardium, the myocardiocytes. So the myocardiocytes become more efficient and heart failure improves. So chronic kidney disease, heart failure, these are situations where early treatment of anemia is important. From our point of view, we are all talking about diabetes today. So we know that diabetes can actually is interlinked with anemia. If there is anemia, we may not even be able to read the HbA1c report properly. So our diagnosis gets stuck up. Management, if we are able to keep our iron levels normal, keep our hemoglobin normal, we can actually improve our diabetes outcomes and we can reduce the risk of diabetic complications. On the other hand, we must make sure that we do not overtreat anemia. We do not increase the levels of iron too much. Otherwise, that can also potentially worsen our beta cell function and also insulin sensitivity. Safe and effective therapies are needed and they are available, oral iron as well as intravenous. Oral iron is something that is so safe, so effective. You should use it in all your patients who have low hemoglobin. And of course, do a test, make sure that there's no other cause like thalassemia, and keep hemoglobin normal. Do not ignore low hemoglobin levels. And also, in many patients with low hemoglobin, if they have conditions where you feel that optimizing iron will improve their health, like for example, heart failure, impaired cardiorespiratory function, impaired exercise capacity, in such patients also, we may wish to do iron studies even if the hemoglobin is reasonably normal. So with this, I'd like to ask our question for today, a very simple question. And the question is, which of the following is correct? Rubro metabolic syndrome or red metabolic syndrome acts as a unifying entity, linking the importance of blood in health and anemia in metabolic syndrome. So Rubro metabolic syndrome is a unifying entity. B, inflammation in metabolic syndrome has no correlation with anemia or iron metabolism. Inflammation in metabolic syndrome has no correlation with hemoglobin levels or iron levels. And C, tissue hypoxia does not arise from anemia. Tissue hypoxia is not related to anemia. And D, none of the above. So which of these is correct? Rubro metabolic syndrome is a unifying entity. Inflammation does not correlate with anemia or iron metabolism. Tissue hypoxia does not correlate with anemia. And D, none of the above. With this, let's look at our questions for today. And lots of questions that have come in. And yes, Dr. Gangadhar, I acknowledge your question and let me just come to it in a minute. Dr. Hiteshwara, credit goes to everybody actually for all these things, and it is just combined learning. 1 plus 1 is equal to 11. The questions that you ask, the queries that you ask, they are so stimulatory, so scintillating, the credit actually goes to that. And as Indian physicians, we should all work together to make our country proud and to make sure that our country is visible on the international academic map. Dr. Vinay Desai says glargine 20. Oh, okay. How do you convert glargine U100 to glargine U300? So it is surprisingly, it is more. 20 units of U100 will actually become 24 units of U300. They have actually not been able to explain why this happens, but roughly you will increase uh, the dose by uh, maybe 10% or 20%. So 20 will become 24. It is opposite. Dr. Gangadhar shares a clinical case, fasting 100 to 111, 2 hour 120 to 140, very good. HbA1c 6.4 to 6.5. Yes, sir, this lab study is compatible. So in India, HbA1c overreports diabetes. That is why 2 out of 3 have to be present. So in this particular case, the fasting glucose is in the pre-diabetic range. Post-load or post-prandial glucose is normal. HbA1c is at borderline of pre-diabetes and diabetes. This case, we will say that the lab reports are compatible and we will diagnose pre-diabetes and we will manage with diet and exercise. One of the reasons why HbA1c overreports is because of iron deficiency in our country. And then the important question, hemoglobin being normal, yes, can the serum iron be low? Yes, it can be low. So what the body does is it tries to preserve the hemoglobin. Total only 4 grams of iron is there in the body. Suppose we end up getting 3.5 grams. The hemoglobin, the iron levels go down. Those 3.5 grams, they will divert all their energy, all their focus on maintaining the hemoglobin. So hemoglobin will remain. But where will we suffer? We will suffer in myoglobin and in cytochrome P. We will suffer at the level of muscle and the mitochondria. So the efficiency of our muscles and mitochondria will go down. We will not be able to exercise so much because of muscle weakness. And because of the mitochondrial dysfunction, we may get heart failure or weakness of the heart muscles as well. So that is actually very true. And how do we diagnose this? Only with iron studies. You have to do serum ferritin, transferrin saturation, and TIBC. Maximum absorption of iron salt. So different manufacturers complain different things, but iron fumarate is something that we use routinely. You can also use vitamin C complexes like ascorbate. Do note that the body is not able to absorb iron just as iron. So it has to absorb it as a salt, as a complex, ferric or ferrous. And Dr. Hitesh raises a very good point. Yes, sir, vitamin D should be taken with iron because it increases absorption. Antihelminthic should be taken before treatment. Dr. DG Parmar asks about 3 plus 3 meals. So, what is the scientific rationale and what is the rationale associated with diabetes therapy? Traditionally, the diabetes therapy that we used to prescribe, this is when I was a student, this used to be either bovine or porcine insulin, basal bolus, or the older sulfonylureas like glibenclamide or chlorpropamide. With both these regimens, basal bolus using bovine or porcine insulin and glibenclamide or chlorpropamide, the risk of hypoglycemia used to be very high and the glycemic variability was high. So we would force our patients to take 6 meals a day, 3 major, 3 minor, so that they would not get hypo. So this is the rationale associated with older therapy. Now with newer therapy, we have SGLT2 inhibitor, DPP4, GLP1RA, modern sulfonylureas like glyclazide, glimepiride, modern insulins. The risk of hypoglycemia is not so high. So we don't need to force our patients. Even a 3 meal pattern can suffice in most patients, or maybe 3 major meals and 1 snack around 11 or 12 noon, 11 a.m. or 12 noon. But regarding otherwise for everybody, whenever you take a meal, that stimulates insulin response, especially if you're taking carbohydrate. If you take only 2 meals a day, there will be a lot of variability. Total hunger is going to remain the same. If you take 2 meals, this is how the glucose absorption will go up. This is how insulin release will go up. And you will have lots of peaks and troughs. These peaks and troughs will cause a lot of variability. The variability will impact the entire body system. If you're taking 6 meals a day, 3 major, 3 minor, you will see that the total appetite is going to remain the same. You will end up eating little bit throughout the day. And insulin response will also be kind of muted throughout the day. You will actually end up with a less uh, variable and a more physiological insulin profile. Even for obesity, when you're taking 2 meals a day. If you're also following carbohydrate restriction, calorie restriction, that is fine. But the weight loss is going to be because of the calorie restriction, not because of the meal pattern. If your total calories is 1,000 calories in 2 meals, you will lose weight. If your total calorie intake is 1,000 calories in 6 meals, even then you will lose the same weight. Dr. Vinay Desai asks if B12 deficiency can occur when hemoglobin is 13. Yes, it can. So B12 deficiency can cause hematological manifestations like low hemoglobin, macrocytic anemia, and it can also cause neurological manifestations. So there is a selective gradient for both. It is possible that B12 deficiency may be causing neurological damage without causing hematological manifestations. Dr. Dheeraj Haldar raises a point. Diabetic kidney disease with anemia, iron deficiency. What is the iron ferritin level before erythropoietin or darbepoetin? So minimum 50 and a ferritin of 50 and a transferrin saturation of 15%. These are the two easy numbers for us to remember, 15 and 50. 15 for TSAT, 50 for ferritin. Lots of other questions coming in, and Dr. Biswajit also says, can I use Ribelsus half tablet a day? It will actually not work, sir, because in semaglutide, we have three strengths, 3, 7, and 14 milligram. All three strengths have got SNAC, SNAC, 300 milligram. SNAC is that molecule which acts like a chaperone for semaglutide and makes sure that it crosses the GIT. So if we break the tablet into 2 or 4, the SNAC concentration will go down. It will go down to 150 or 75, and the semaglutide will not get absorbed. However, we are mindful of cost. In some of our patients, we use Ribelsus mainly for glucose control. In others, we use mainly for appetite control, and in yet others for both of them. So some of my patients, what they're doing is, first I put them on 3 milligram OD, then 7 milligram OD, then 14 OD. And then what they figure out is that even if they take 14 milligram every other day, every alternate day, their appetite suppression is taken care of and their glucose levels are also controlled. So you can try that, Dr. Biswajit. 14 milligram every other day. Warm greetings to Dr. Gauri Shankar Dharmaraji. Welcome, sir, and I thank you for being with us in this journey of diabetes education, diabetes learning. For a diabetic patient with hemoglobin 9.5, allow me to declare conflict of interest, but Vitcofol is a good drug that I use. Vitcofol at night. When to check hemoglobin? So the hemoglobin will begin rising after 21 days. Before that, it will not rise. So for the first 21 days, you just talk about quality of life, well-being, and we can check the hemoglobin after 1 month, and then at monthly intervals. Do inform the patient that HB may not rise for 21 days. Don't get upset. Some patients do feel a sweet taste with iron preparation. That is right. You can just change the company and see. Just keep on trying to change the companies. And they can take liquid also if they are not diabetic. Though do counsel your patients. If they're taking any iron syrup, they have to brush their teeth immediately. Otherwise, there will be black staining. How to treat iron deficiency in general OPD? So for general OPD, just look at the patient's tongue, the nail beds, and also the conjunctiva. Give 1 tablet of mebendazole and start an iron preparation. Tell the patient that we will give this for 4 to 6 weeks. If your hemoglobin improves and you feel better, we will continue. If your hemoglobin normalizes and you are feeling perfect, we will reduce the dose. In young men, in postmenopausal women, we will stop the dose. In young women of reproductive age group, the ones who are menstruating, we will continue iron in maybe lesser doses. One simple way in young women can be to give iron for 10 days in a month, in every month. That will take care of menstrual loss. Also counsel the patient that if you don't feel well after 6 weeks, then we will do another test that can be depending upon our OPD practice and how much money the patient is willing to spend. If we had not done a hemogram initially, peripheral blood film, we can do that after 6 weeks. If we had not done iron studies, we can do that after 6 weeks if patient is not responding. We should have a definition for quality of well-being. So in the one patient, it may be, I get breathless when I walk 500 meters. So then we will say, madam, after 3 weeks, you should be able to walk 1 kilometer without getting breathless. So we should have that kind of an agreement with the patient. So for 16-year-old girl with hemoglobin 10.8, a very good idea would be oral iron. Vitcofol is a good example. one tablet at night for about 3 months, and then one tablet at night for 10 days in a month for the next 30 years. Folic acid as routine, Dr. Gauri Shankar, for everybody, because folic acid and vitamin B12 deficiencies are also endemic. So practically every patient will get folic acid. Some patients who have pernicious anemia, who don't respond, who have megaloblastic anemia, extra vitamin B12 may be required, whether injectable or sublingual. 10-year-old girl feeling numbness, feet, paresthesia, fatigue. I think all, first of all, balanced diet. बिटिया को बोलेंगे that the flag of India has got 4 colors. So each and every plate should have 4 colors. So have a colorful plate at each meal. Lots of colored fruits, vegetable salads. Also give vitamin D, B1, B6, B12. And if hemoglobin is low, we add iron. Encourage exercise, outdoor exercise, and you will find very good results in 2 weeks. All poorly controlled patients do feel fatigue and malaise. So hemoglobin would be the simplest way to diagnose anemia. If your patient has symptoms of heart failure, uh, severe fatigue, which is actually impacting his or her health, then there is no harm in doing an iron study also along with that. Easy fatigability, let us remember the lemon mnemonic, LEMON, L for lifestyle, E for endocrine, like thyroid, testosterone deficiency, M for metabolic, like diabetes, blood pressure, the diabetes medications, the blood pressure medications. Beta blocker can also cause fatigue. O for orthopedic related, are the bones okay, are the muscles okay? And N for nutritional, is the macronutrient and micronutrient balance maintained in our diet? If we can cover these, fatigue usually becomes okay. And maybe later on, we can talk about diabetes fatigue syndrome in one of our programs in the future. Iron injections do help in diabetes, and in my OPD, I have seen that fatigability actually responds. So, if your patient has very low TSAT, transferrin saturation, very high TIBC, Dr. Ashirwad has asked about that, total iron binding capacity, if it is more than normal, more than 400, and if the ferritin is low, then a single injection of ferric carboxy maltose actually does wonders. Depending upon the severity, you may have to give 1 or 2 or 3 injections. It is given in normal saline. Patient has to lie down for half an hour, so you need take care. In all these patients, very confidently you can counsel them that, madam, for the first 3-4 days, nothing will happen. But within a week, you will feel a kick. This iron will enter your muscles, it will enter your liver, it will enter your cells, your mitochondria, and you will see a magic that occurs in your fatigability. Shashi Khanna ji asks, platelet count slightly low, hemoglobin 14.5, no clinical significance, we don't need to worry. Tell patient to eat a balanced diet with lots of colored fruits and vegetables, and not to spend too much of money on goat milk and on guava leaves. And also, good evening to Dr. Anshul Singhai from Bhilai. Warm welcome, sir. Metformin-induced anemia, not very common in my practice. Very rare. Optimal level of hemoglobin in minor thalassemia, Meenaji, I think is 10 to 11. Though if someone else can correct me, maybe Dr. Anshul knows the right answer. I would be happy to stand corrected. 10 to 11. And no matter what we do in minor thalassemia, we will not be able to take the hemoglobin up till 14 or 15. So we shouldn't try too hard. Semaglutide does help in de-addiction. So I have not noticed this yet in my OPD for nicotine de-addiction or for alcohol de-addiction. But with liraglutide, so many of my patients used to come and tell me that they don't feel like drinking alcohol anymore. So actually, the receptors are similar. And semaglutide, you can try. If your patient has diabetes, do take a history about tobacco intake and alcohol intake as well, and see if the intake comes down. I think we will be pleasantly surprised. So thank you to Dr. AR for raising this point. And Nitin Narulaji asks about body pain. We just talked about fatigue. The focus will be on lifestyle, nutrition, and exercise. And thanks to all of you for raising these questions. So tiny iron, just 26 atomic weight, total weight 4 grams in our body, and so much discussion that we can have. Dr. Gajanan Sanap says CKD and diabetes and insulin in CKD. Certainly, we will do this and we will remember to take this topic. And Dr. Dheeraj Haldar says Addison's. Okay. The question is Addison's disease with postprandial hyperglycemia, which will be better. First, we give metformin. Semaglutide, SGLT2 inhibitors, both will be helpful. Uh, Both are fine. You can use either one. If you are worried more about heart failure, SGLT2 inhibitors will be better. If you are worried more about atherosclerotic cardiovascular disease, semaglutide will be better. If we want to reduce weight, then semaglutide will be better. And of course, cost will play a role in our decision making, but both are equally good from a scientific standpoint. I'd like to thank everyone for the discussion today. It is so nice, and even though it is Sunday night, it is late in the day. All this discussion, these questions, they actually invigorate me. They rejuvenate me, and they keep me ready and waiting for the next Sunday when I can meet all of you. So thanks once again for this wonderful discussion, and I'll have to hand over back to Team FDC. And
Thank you,
I
sir.
wonder,
Today, I
Team
think we.
Team FDC, we have a question for you as well.
Yes, sir.
What are your favorite brand names of iron?
I personally feel, sir, Vitcofol is a very economical brand looking for the masses. We have got Vitcofol capsule, which is just 3 rupees with 100 milligram elemental iron, folic acid, B6, B12, and zinc. At the same time, those who have a no, affordability, we have got Vitcofol HB, which is the latest nano size iron particles, which increases the absorption and directly gets delivered to the liver. Is also available with us. So personally, for me, with Vitcofol HB and Vitcofol does better. But sir,
That
today I
answers.
think we have spent almost now 12 minutes in discussing the question answer, and that really tells us that the requirement of the knowledge when it comes to simple topics from iron management, taking it to diabetes, and now to diabetes and kidney disorders. And today I seen a lot of questions coming in the heart failure cases also has literally told us that these sessions are very meaningful to the practitioners in India, and we love to have every Sunday 9 p.m. with Dr. Sanjay Kalra. So, sir, thank you very much. Jai Hind.
Jai Hind.